will not get necrosed that easily. So if at all you have to do an endodontic treatment, you can do only for the coronal part. Right? Got it? So the radicular part does not require any treatment at all. It's going to stay there like that. Okay? So the main idea is endodontic treatment should not be done immediately. Now this is also different from your previous guidance. You should wait for a period of minimum 2 weeks to do any endodontic treatment on any fractured teeth. Be it any kind of fracture, be it avulsion, be it luxation, be it lateral luxation, be it any kind of fracture, be it hard tissue, soft tissue, you are not starting your endodontic treatment earlier than 2 weeks. You are going to wait 2 weeks, you are going to recheck the vitality, whatever methods you use, and only then you are going to do an endodontic treatment. Same thing holds good even for a root fracture. So this particular patient, she was an old patient of ours. I mean, she attended puberty, she had a lot of domestic issues, so she stopped coming to our, stopped coming for follow-up. And this is how she came to us, after a break of around 3 years or something. And what we noticed was she had a root fracture. The root fracture, and that is the crown of the fracture. Now this patient is almost now 12 years of age. Now the idea of pediatric dental traumatology is, the first goal is saving the tooth. We want to save whatever is possible. Why? Why am I standing here as a pediatric dentist and asking you to save whatever little bit of tooth is there? Even if it's a root, if it's a half the tooth, save it. Why? Why am I so particular? Yes. Exactly. See, the surgeon speaks simply because if at all the patient wants to go for an implant, there should be some amount of alveolar bone. Without the tooth, what happens there? Without the root, without the tooth, yeah, there is severe resorption. You cannot have a good aesthetic profile when the patient gets into her age when she can go for an implant. Okay. So the primary idea of this particular patient, and even I will be discussing few more patients. This patient is 12 years of age. So what we want is to have something there until the patient is of age when she can go for an implant. Now that is the condition of her tooth. So this was an RC treated tooth. The patient did not come back for the crown because she didn't have any symptoms, and when she came, this was a condition. So what we did was the lower part, that is the cervical segment. Since it was not mobile, we didn't have a need for splending. If it was mobile, we should have splended. Thankfully, it was not mobile, it was locked. So we just retained it like that. We removed the GP from the lower segment, and the lower segment has got a, is there any apex for the lower segment? I said do an endodontic procedure for the lower segment. Is there any apex for that? Is there any closure there? So if I give GP there, what will happen? Can you get the 3-dimensional seal? No. So the idea is the lower segment, the cervical segment will be treated as apexogenesis or apexification. The lower segment will undergo a process of apexification and the upper segment will be left as it is. So that is how we want the healing to take place. So we fill the lower segment completely. This was an intracanal medicament that was given for 3 weeks, and we fill the lower segment entirely with biodentin. Now this biodentin, as I said, is a bioceramic, so it is going to act upon the neighboring structures, and we are expecting a hard tissue union between both the fragments. Now this patient is under follow-up, so that is for root fracture. So anywhere, if at all you could retain a particular length of root or tooth inside the oral cavity, that is very good. Okay. Now we are coming to luxation injuries. Now luxation injuries, yes, all this you know, right? You are going to splint the tooth. The splinting time has reduced. Okay. So it's like, if at all there is subluxation, first thing is do not do anything. Mild subluxation, you do not have to splint. If it is excessively mobile, then you can splint for 2 weeks. Extrusive luxation. What is extrusive luxation? Extrusive luxation. The tooth has come out of the socket. The tooth has come down out of the socket. So when it has come out of the socket, what we usually do? Put it back, right? If it's come out, put it back and splint for 2 weeks, 2 to 4 weeks, okay, depending upon the condition of the patient. You can splint a passive splinting, okay. Passive splinting is like it's not going to, it's going to have some degree of mobility to the tooth. Otherwise, it's going to result in some kind of resorption or ankylosis. So we want some degree of mobility. So you're doing a passive splinting for 2 to 4 weeks. But again, subluxation will heal without necrosis. There is not going to be any necrosis with subluxation, but extrusive luxation and every other kind of PDL injuries, you should monitor for pulpal status. Okay, so extrusive luxation, you are going to monitor the pulpal status after 2 weeks. First, when the patient comes to you, that will be your baseline vitality testing. After 2 weeks, you will confirm. Lateral luxation. What is lateral luxation? Yeah, the tooth has moved either buccally or lingually. Either it's come out or gone in. So that is called lateral luxation. Okay. So lateral luxation, what do? Any kind of luxation, we want to put the tooth back in its position and splint. So we are going to put it back in the position and splint for 4 weeks. Here also you are going to check the status after 2 weeks. Now here again, in case of an immature tooth and mature tooth, the treatment plan is going to vary. In an immature tooth, even if the pulp status is going to be negative after 2 weeks, you are not going to do anything because, I'll keep repeating this, because stem cells are there. Spontaneous revascularization will happen. So do not attempt anything unless and until you can establish a clear non-vitality in an immature tooth. For example, the patient comes to you with a pus discharge. The patient comes to you with a discolored tooth. The patient comes to you with an excessive mobility, a periapical lesion. Only then attempt for endodontic procedure. Okay. Until then, you can wait. Even if your pulp status is going to be negative in case of immature tooth. Mature tooth, if your pulp status is negative, do not hesitate. After 2 weeks, immediately go for a root canal treatment. Are we fine here? Or is it going too much above your head or something like that? Are you fine? Is it good? Yes, I'll continue. Thank you. Next, intrusive luxation. What is intrusive luxation? The tooth is gone inside. Now, among all the PDL injuries, which is this, since I put this slide, probably this you would guess, this is supposedly the most severe form of injury. The most severest form of injury is when the tooth gets crushed in. Okay, now initially intrusive luxation, now in all these lateral luxation, intrusive luxation, the newer guidelines is when to start your endodontic procedure. The guidelines very clearly states that do not start it. When are we supposed to start? After 2 weeks. Okay, any kind of lateral luxation, any kind of PDL injuries, start the procedure only after 2 weeks. Do not attempt before 2 weeks because you are going to give the tooth a space to heal. If it's mature, if it's immature, give the tooth a space to heal. Okay, so do not attempt endodontic procedure immediately because let's say there was some vital tooth inside, you are depriving the patient or depriving the tooth to be vital. It would have gained vital. Because non-vital tooth, what happens? Once you are done with RCT, that's it. The patient has to have a crown, the patient has to have all the complications of, an unnecessary treatment. So, like what sir said in the last lecture, do a treatment only when it is absolutely necessary. Okay? So, now intrusive luxation, what happens is, if at all it is an immature tooth, what happens? The tooth starts coming out. Okay, there will be a spontaneous re-eruption in case of intrusive luxation. Now, when does it happen? How long should you wait for the tooth to come out? That's the question, right? I am waiting for the tooth to come out. How long should I wait? You can wait for a period of 2 to 4 weeks. Okay, so within 2 to 4 weeks, in an immature tooth, if it doesn't come out, then you have to surgically reposition it or orthodontically extrude it because the tooth has become locked there. Okay, if you are going to leave it for more than 4 weeks, the tooth will get ankylosed. So within 4 weeks, if the tooth is not showing any signs of re-eruption, definitely you have to pull the tooth out either by orthodontically or by surgically, and then you have to splint it and go ahead with your endodontic procedures. Now let's say in a mature tooth you have got a lot of values there. So when the tooth is between 3 mm, if it is intruded, wait. Okay, for it to re-erupt. 3 to 7.
Common problem. Can you wait for spontaneous eruption for so many days? Because parents will be panicked with the position. Is it relevant if you do it immediately so that?
No, because see, that's what I'm coming back now. Initially, it was believed that because intrusive luxation is a severe form of injury, endodontic treatment will be invariably required. That was the dictum. Why should I wait? Anyway, I'm going to do an RCT. Why should I wait for 2 weeks, 4 weeks? I'll pull the tooth out, I'll create much more harm, and then I'll do an RCT. No. Now it says that there is always a chance for spontaneous healing to occur. So do not trouble the tooth more than it has been troubled. So explain to the parent why you are waiting. Ask the parent to take series of photographs. Give the responsibility. That's how we do it. We give the responsibility to the parent. Take daily photographs. Keep sending it to me once a week. So the parent knows that the doctor is actually interested in, in the follow-up. So the patient is given a responsibility, patient's parents is given a responsibility to, monitor regularly. So, and you should tell, like if it's not coming out in 2 weeks, if it's not coming out in 4 weeks, then yes, we are going to intervene and we are going to pull out. And take it from me that the parents are really happy if we don't intervene, because it's a huge procedure, taking it out. Splinting. Now splinting in a child is not at all easy. I don't know how many of you have attempted it. It's not easy. Salivation. I'm not talking in general anesthesia. I'm talking in local anesthesia. Splinting, there is salivation, there is cooperativeness of the patient, and then eating comes in. Okay, the child will come back to you with a broken splint, because the parent is. As a parent, you cannot stop the child when the child does give me some snacks. Amma murukku kuduma, chips kuduma. The parent will give, and the splint will break. And invariably, you are going to trouble the patient, you are going to create more harm than that is necessary. So whenever there is an intrusive luxation, whenever the nature can help you, use that. In pediatric dentistry, that's what I keep telling. Nature has got, nature helps children a lot because they are growing. Nature somehow comes in and helps them. So allow the nature to heal by its own. So that is it. So now, if the tooth is 3 to 7 mm intruded, you can either opt for an orthodontic extrusion or a surgical extrusion. Now if it is more than 7 mm, no point in orthodontic extrusion, go for a surgical extrusion. Okay? Now avulsion. You remember the photograph I put in the starting, this is an avulsion, right? Now this particular slide is not meant for doctors. It is meant for people who are there at the site of the injury. Then why did I put it here? Because as doctors, I want you people to educate all the parents who are coming in. If at all there is a school teacher, if at all there is a parent, if at all there is a child who has got a risk for developing dental injury, the child, the parent, the school teacher must be informed what has to be done at the site of injury. Now, at the site of injury, first, how do you pick up the tooth? You do not pick it up by the root. You pick it up by the tooth, by the crown. And do not attempt to, clean it vigorously. No. If at all you can find water, clean it. Otherwise, no. Put the tooth back in. If at all you want to clean it, ask the child to spit on it. The saliva is an excellent medium. So ask the child to spit on it. So some amount of cleaning is done. Just put it back. The child only has to bite on a handkerchief, or just keep biting until the child is brought to the dental clinic. So this has to be informed to every parent, because the best treatment for avulsion is putting the tooth back in as immediately as possible. Do not wait for a dentist. Do not wait for the tooth to be clean and it is scrubbed, polished, clean. No. Put it back immediately. So that has to go to all the, I really wish it goes to all the, parents and children and school teachers visiting your clinic. So that's why I put it. This is what happens at the site of injury. Now, after the site of injury, the child is coming to you. Okay, so it's very important to encourage whoever the caregiver is to re-implant the tooth immediately. Do not bother if the tooth is in its position, not in its position. I do not know to do it. No, just put it back. What if the child swallows? No, just put it back. Ask the child to bite on it. Because the benefits of having a tooth there outweighs all the other risks. Okay. Now, let's say the extraoral time is less than 60 minutes and the patient is coming to you. What do? Re-implant, right? A very favorable condition. The extraoral dry time is less than 60 minutes. It is brought in what are the best medium? You should know all these medium, right? Tell me a few medium. Yeah, saliva. Then? Yeah, coconut water, milk, anything. See, water might not be a great medium, but that is available everywhere. Rather than bringing it dry, if the child can bring it in a tap water, best is having it in the sulcus of the mouth, bringing it in a tap water, any kind, so that it doesn't get very dry. That's the idea. Best medium is, you have HBSS, coconut water. If it is difficult to find, at least water. Okay, so now the child has come to you with less than 60 minutes and the tooth is in a wet state. What do? Reimplant. Now, the extraoral dry time is more than 60 minutes and the tooth is brought to you in a dry state. What do? What do? Reimplant. Even if the extraoral time is more than 60 minutes, if the tooth is brought to you in a dry state, wet state, you reimplant. Now the third situation. Extraoral time is much longer than 60 minutes. The tooth is brought to you after 1 day. After 2 days, what do? Reimplant. Okay? That's the thing now. Okay? Delayed reimplantation works. Do not hesitate to reimplant whatever condition the tooth is brought back to you. But remember to tell the patient that this is not the final treatment. This is not the final. So there is something called outcome. Every treatment has got outcome. Now what would be the outcome of the last two things? Ankylosis. Ankylosis, in the other sense, we can call it as replacement resorption. That is, your tooth will start resorbing and it will get replaced by the bone. Clinically, how do you know it? Clinically, the tooth might go into an infra-occlusion. So always tell the parent why you are doing this and what could be expected. So do not tell the patient that this is the entire clinic treatment plan. No. This is a temporary treatment plan to retain the tooth in the cavity until it is okay. How long the tooth is going to stay? It will stay there. If it's going to if it's going to shed in 2 years, fine. If it's going to shed in 5 years, it's fine. The idea is to take the tooth until the child can receive an implant. Like how I said about root fractures, like how I'm going to say the same thing about avulsion also. So if you can, allow the alveolar bone to form there. So having said this, do you think replacement resorption is a good outcome or a bad outcome in avulsion? You cannot say it's a bad outcome because you are allowing the bone to form there and only you do not want the tooth there because the tooth is anyway going to go in. Okay, so the tooth will get resorbed and the bone will form. So do not hesitate to reimplant even if the extraoral time is more than 60 minutes. If it's 48 hours, if it's 24 hours, do not hesitate. Put the tooth back in. If at all you can manipulate the socket. If the socket is completely healed, then you can't do anything. But if at all you can manipulate the socket without creating a fracture of the tooth, let's say it's after a week and you try putting it in, no, it's not going to work. But let's say the socket is there and you can manipulate it, you can clear the coagulum, you can put the tooth back in, yes, very good. So again, open apex, even in case of avulsion, open apex they say, what do I have written there? Do not go for an endodontic treatment, even in avulsion. Avulsion is, the tooth has fallen out, you have taken it, you have put it inside. Even then, if it's an immature apex, do not go for endodontic treatment. Wait, the pulp will heal on its own. The teeth will heal on its own. Only if it's a closed apex, you should initiate endodontic treatment after 2 weeks. Do not wait for any vitality testing. It's not going to work. So if it is a closed apex, definitely start your endodontic treatment after 2 weeks. Fine? Fine with this? Yes. Now I'm going to show you this particular case. Okay. So this case I started in 2017. 2017 September. Now whatever I'm telling now, this extraoral time more than 60 minutes, that was the guidelines in 2020. But this particular case I attempted in 2017. The patient came to us, the extraoral dry time was 48 hours. So there was a huge question. The patient had gone to another dentist, the dentist had referred here. So I wanted to put back the tooth in. Now the parent was not at all willing for it. The parent was literally scared, saying that adu veshapalluma, adu ulla pota en pillukku edavadhu aidum. So I had to convince the patient, which might not be a good approach, I'm not sure about that. But being a child and after knowing what all the ill effects could come, when the tooth is not there, I tried convincing the patient. The patient kind of brought, the patient's mother kind of bought it. So we went ahead and we did a reimplantation. So that was a reimplanted tooth. And we went ahead and we did RCT. Now the initial consensus for an avulsed tooth was to do an extraoral RCT and put it back. If you have read it in your textbook, you must remember. You have to do an extraoral RCT and then put it back. Now what I thought was, the tooth is already damaged. The Tooth is already coming after 48 hours. Why should I damage it more? I'll put it inside, I'll wait, and then do an RCT. So this is what happened. So I put the tooth back in, I waited for, not 2 weeks, I waited for almost 10 days or something. And then I started the RCT when the splint was in place. So the RCT was done. And this was the state after, I think, 2 months, 3 months. Can you see the replacement resorption starting in there? As early as 3 months. Can you see 2 months or 3 months? The half of the root is gone. Now, this is in 6 months. Can you see in this? I think this radiograph would be better, I think, right? Can you see? This here. Can you see? A replacement resorption, a bay-like area, a radiolucent bay-like area forming here. So this is exactly what happens in case of avulsion. A replacement resorption happens. Now if you could measure and see, this is in 2 months, this is in 3 months, and this is in 6 months. You cannot see an appreciable amount of resorption. Now I'll show you something. So this is in 6 months or so. Now this patient is 17 years old. The patient came to me when he was 11 years old or something. Now the patient is 17 years old, and that's the tooth right there. Can you believe? That's the tooth right there. This tooth was reimplanted after 48 hours. So this is how the patient was, this is how, and this is how after 17 years. Now this patient is going to receive an implant in 2 weeks. The bone fill is good, the patient is fine. So this, and you can check the radiograph. Can you see this? The amount of replacement resorption in 7 years, it's only so much. So what has happened here? The replacement resorption has stopped there. So probably this can be called a successful treatment, but what I like the most in it is there is bone fill. The patient can go for an implant and the kid is quite happy. Actually when the patient came in, I was suggesting, if you see at this stage, I was suggesting an orthodontic treatment for the kid. But now at 17 years, he's quite happy with whatever nature has taken care of it so much that he's even happy with the dentition. He's not willing for an orthodontic treatment and he just wants to get the tooth fixed. So that is your beauty, You do not hesitate to put back the tooth in. So now coming to the second part. Okay, so primary tooth injuries. How do you like treating a child of 3-year-old crying with blood oozing from the oral cavity? Yes, you like? You're quite happy? No, I don't think so. Even me, as a pediatric dentist, I get really worried when a child comes in with blood oozing and a crying parent, it's such a chaotic environment that it really clouds our judgment. That is why I find primary tooth injuries are the most neglected. I find this kind of attitude very common among most of the dentists with the parents. But this attitude is quite common. But do know. Like how you give importance for dental caries in a primary dentition, give importance for dental injuries also. Now these are the reasons why you hesitate, right? You have an over-anxious parent there. You have a primary tooth, you're not sure, okay, if I treat this tooth, what would be the situation of the overlying tooth? There is a permanent tooth right there sitting. Now I do something, it harms the permanent tooth, the parent is going to come back at my throat. So better I'll extract it and leave. So that could be another reason. Then of course, behavior management, all that. So but what happens when you extract a primary tooth? What happens in a child who is 2 years of age? We all have kids, right? So at 2 years of age, what is their developmental status? They learn to speak. Am I right? They speak when they are 2 years. They learn to speak well. Of course, they learn to speak even before that. But after 2 years,